we'll finish the 2 lectures now, and tomorrow we'll finish everything, wrap everything up, so that you will have next week free, from pathology. So we come to actually stop. We stopped yesterday or the day before at metastasis, and metastasis is the process in which the tumor cells will actually break out of its original shell, of its original primary site, and metastasize to distant sites. Could you please close the light if you don't mind? Or dim the light.
1 and 2, 1 and 2.
Thank you. All right, so it is a very important feature to differentiate between benign and malignant tumors. It is probably the most important feature to differentiate between benign and malignant tumors. As I mentioned to you, there are the other features. Even with invasion, that's really like, I would say you could see it in benign tumors. It's rare, but it is not unheard of. Whereas with metastasis, like 99.999%, it is always with malignant tumors. How does it happen? Usually going through the supply of the original, organs, either going through the lymphatics or the blood vessels, either the arteries or the veins, more likely with the veins than with the arteries, and finally, through direct extension or seeding of body cavities. We'll talk about each one of those. Now, why is that important? It is important to talk about metastasis, because you have to know that really a lot of the tumors, probably I will refrain from 50%, but this actually you find in a lot of different resources. You find it even up to date, 50% overall of all new cases. I guess the guy is closing it and not closing it the right.
1 and 2.
That's the number.
First 1, 2, 3.
No, just 1, 2.
Just over this is this. The first. All right. So how about this? A large number of patients who usually present with metastasis. I would not want to say 50% or more, but this actually comes courtesy of emedicine.com and also of UpToDate. That's a very high number actually of cases. Why is it important to actually focus on metastatic kind of presentation for cancer? Because once there are metastases, then cure is something that you cannot talk about anymore, because the surgical option of management is no longer there. So as a result of that, you would feel that the whole medical establishment has failed really the patient when a patient presents with a metastatic tumor rather than with a primary tumor. Really the best way is to try to prevent the tumor from happening. But if you want to get it, you want to get it when it is the smallest that is around. When, as I mentioned to you, stage 1A, the only curable, quote unquote, you put curable, quote unquote, because you still really don't know. You don't talk about a cure when it comes to tumor treatment until after like 20 years. Because metastasis could happen 15 to 20 years later after the resection of the original tumor. Still, like with stage 1A, this is the only luck you have if you could catch the tumor at that stage and treat the patient with surgical resection. If there are metastases, then forget about it. The metastatic aspect of oncology is so important that there are some tumors where you open actually the patient, when you discover that the patient is having a tumor that is highly metastatic, you simply do not even attempt to resect the tumor. Example of that, what you see, for example, with small cell cancer, small cell lung cancer. They take the patient to the operating table to sample the tumor, to know what tumor, what is the tumor, and to see also the extent of the tumor. If they find out that the tumor that is, that the patient is having is a small cell lung cancer, the presumptive thinking is that the tumor has already metastasized, and that actually surgery is no longer an option. You simply close the patient without working up the extent of the tumor and send him home, because the option for treatment for that patient is chemoradiation. It is not surgery. Do you see how important it is to know what type of tumor in terms of its ability to give rise to metastasis? Again, because the presumptive thinking is that small cell cancer has already metastasized by the time of diagnosis. So this is why you cannot really do the surgical option. So it is very important to figure this one out, and there are a lot of work that is being done now to figure out which tumors are more likely to give rise to metastasis, what you call biomarkers of metastasis and invasion of malignant tumors. Okay, so the more anaplastic the neoplasm, the more likely to have metastasis. Not only that, actually, not all the tumor cells, metastasize. It is a subclone that is a very sturdy, very tough kind of a subclone. A subclone that will be able to evade the immune system on its way to the distant side. And I told you how it could do that. It could do that in a couple of ways. A subclone that is able actually to withstand the fact that you may have very hostile environment in the place where it is going to, in the metastatic, nest, where it is going to. So it's able to live under very dire, kind of conditions, including very little, blood, very little ATP, on its way to establish, the blood network and, the tumor mass in the process. How does it do that? It does it through a couple of ways. One of them is the lymphatic spread. Going through the lymphatics of an organ, on its way to the lymph node that are draining that site. Now that's probably the best, if you want to have really a little bit of, what do you call it? Like in a strange way of looking at things, it is probably the best thing that a malignant tumor patient could have, the lymphatic spread. The reason for this is that the lymph nodes will act as actually a retarding agents. They are going to act as a trap for those tumor cells on their way to the blood. Everything is going to drain eventually into the blood, so into the lymph nodes, and then from the lymph nodes into the thoracic duct, and then from the thoracic duct into the blood. As a result of this long process, the epithelial tumors which favor the lymphatic spread has a better prognosis than the sarcomatous tumor, the malignant mesenchymal tumors that favor the hematogenic spread. Not all the epithelial tumors, not all carcinomas favor the lymphatic spread. Some of the carcinomas favor the hematogenic spread, such as follicular carcinoma. As a result of that, follicular carcinoma of the thyroid has a worse prognosis than the papillary thyroid carcinoma. The reason for this, papillary favors the lymphatics, the follicular favors the blood. So you can see difference in prognosis between the two patients. Now, right, so how does it spread? Usually that's going to follow the normal, lymph drainage. So this is how you do it in the lungs. You do it actually station by station to figure out what is the extent of the tumor, if it's non-small cell lung cancer, and is it amenable to resection or not. How do the lymph nodes, feel and look? They look enlarged, usually they are enlarged, but they are going to be painless. That's an important actually distinction, feature between an inflammatory lymph node versus a neoplastic, lymph node, or a lymph node involved by a metastatic tumor. The lymph node that is involved with an oncology process will be painless, as opposed to that, of the inflammatory, process, if it's draining an abscess or if it is involved in a systemic kind of inflammation. Now, not only that, actually, the lymph node that is involved in metastatic spread will be hard. A lot of times, you will see that the tumor has gone out of the capsule of the lymph node and into the nearby tissue, resulting in what is known as extracapsular extension, which is in some tumors is a very poorly prognostic feature for that tumor. Here is an example of that. This is the original tumor, and in nearby you see an invasive edge, infiltrating edge of this tumor, and here there is a lymphatic vessel where you see that it does have a tumor embolus. Now you look actually in the lymph node, and this is how the draining lymphatic vessels will bring in the tumor to the lymph node. Usually the first site to be affected is the subcapsular space, and that's usually, this is the area right here, and that's going to be the area that is first affected. In this case, it is a lymph node that is affected with metastatic colonic adenocarcinoma. This is pretty easy to diagnose because those glands have no place right here in the lymph node. But a lot of times, the metastatic elements of the tumor will not be in the form of glands, rather they are going to be in the form of single cells. And you can imagine how hard it is going to be to differentiate some of the tumors that have, for example, small cells when they metastasize to a lymph node from the rest of the lymphocyte. In this case, you have to do some immunohistochemical markers that is going to light up the tumor cells that are going to separate them from the rest of the lymphocytes. All right, so this is a metastatic tumor to a lymph node. Here is the hematogenous spread, usually favored by sarcomas, by malignant mesenchymal tumors. As a result of that, overall, you will see that sarcomas have a worse prognosis than carcinomas, and for the reason that I just mentioned to you in the prior slide. So what is going to be invaded, you will see that veins are more likely to be invaded because their walls are thinner and much easier to penetrate than arteries. But arteries do not shy away, they are involved sometimes. Example of this kind of spread, example what happened actually in the colonic adenocarcinoma. This is an epithelial tumor, and when it tries to metastasize, it will give rise to this metastasis through the portal circulation into the liver, resulting in multiple kinds of metastasis. Or any kind of tumor that gain access to the vena cava, that's going to take it to the blood, to the heart, to the right side of the heart, and from there to the lungs. As a result of that, the lungs are the most common site for secondary metastasis, and the most common site in the body receiving metastasis from somewhere else, followed closely by the bones, especially the vertebrae, especially the lumbar vertebrae. So here in this section, you have a malignant tumor right here that is in this part of this section, and you can see actually that nearby there is a vessel that has a tumor embolus. So one way to figure out if you are actually, if this is a true embolus and nothing that you have done as a result of cutting through the tumor, because when you cut the tumor, what's going to happen sometimes, with your blade, you may introduce actually a piece of the tumor inside a vessel. So there, you want to make sure that this is actually a true embolus and not something that you are doing. That's when you start to do deeper cuts. And if it's still, if the embolus is still there, then you would know that this is actually a true embolus rather than something that you have, caused with your scalpel. Now, you see that this tumor also, another indication why this is actually a metastatic tumor, is that if you see that the majority of the tumor cell, almost 50% of the tumor cells, have this kind of morphology. So pretty much everything is dark, which is what you expect from a malignant tumor, right? That the tumor cells will have mostly nucleus. That's really where the what's happening in those cells, and they are in a state of a hyperdivision, and C ratio has increased a lot. But then you start to see red here. What are these red stuff? Do you guys know?
Angiogenesis. The blood itself.
No, not RBCs. No. Good thought, but not RBCs. Necrotic cells. Necrotic cells. So what kind of tumors give rise to necrosis?
Malignant.
Usually not. It is a malignant tumor to start with. Usually the high-grade kind of tumors, the really anaplastic type of tumors. And the reason why it gives rise to necrosis is because of the fact that it's going to grow in size so fast, it will outstrip the growth of its own blood supply. As a result of that, there will be large areas within the tumor that are going to die as a result of this very fast growth. So that is an indication actually showing you that not all tumor cells will metastasize. Rather, the gritty, the tough ones are going to be doing this. The high-grade cells are going to be the ones that metastasize. Is this clear? Good. Here's an example of actually metastasis to the lung. In this case, it's going to be in the form of hematogenous metastasis to the lung. Each one of those tumor cells have theoretically the ability to, or has theoretically the ability to go on to develop into a metastatic nodule. So you would have what we have talked about before, what Arnold Schwarzenegger called a puncture gun appearance versus what the British call cannonball appearance. Simply what you call a field effect. So this bullet that is going to fragment into so many shrapnels, and it will go and affect that site where it's going to, it will result in so many injuries and so many damages, in this case so many nodules. Each one of them was a metastatic cell at one point in time, was able to grow to overcome the defenses of the lung in this case and grow into its own tumor nodule. Here's an example of metastasis to the bone, the second most common type of metastasis to an organ. You will see that second most common place where metastases go to. You will see that this is an osteoblastic metastasis. osteoblastic metastasis, meaning metastasis that actually going to make bone. And you will see that, in terms of the tumor that, make osteoblastic metastasis, the prototype of this is going to be prostatic adenocarcinoma. It is not really the tumor cells that make the new bone, it is the osteoblast that gets irritated by the adjacent tumor metastasis. So those osteoblasts will start to lay down a new bone. And you know that this is the case because the alkaline phosphatase in those patients is going to increase. That's an indication of the activation of the osteoblast. So it is really the osteoblast laying down the new bone, not the tumor cells laying down the new bone. Now, if you look, this is actually prostatic adenocarcinoma metastatic to the lumbar vertebrae. In this case, these are actually metastatic malignant melanoma to the lumbar vertebrae. How do you know they are melanoma? Because it's filled with this melanin, right? So in this case, those cells of the malignant melanoma tumor have retained the ability to make melanin. As a result of that, when it goes and metastasizes, it will retain that ability, and it's showing up in this very dark color. Okay. All right, now seeding of body cavity. What happened here is that cells from the tumor mass are going to exfoliate, are going to break out, and they are going to reach some body cavity. Example of the body cavity where they go, including the peritoneal cavity, pleural cavity, or the CSF in the CNS. So usually for that to happen, the site of interest is going to be filled with fluid or has some fluid in it. In this case, peritoneal fluid, pleural fluid, or the cerebrospinal fluid. Those cells are going to bathe themselves in these fluids, and they are going to gain access to all the organs in that site. So in this case of the peritoneal cavity, especially with tumors such as the serous ovarian adenocarcinoma, you're going to be seeing serous papillary adenocarcinoma of the ovary. You will see that those tumor cells are going to base in the peritoneal cavity and gain access to all the abdominal cavity. So you will see this kind of configuration. You'll see tumor nodules that are rising, in this case on the mesentery, and rising pretty much everywhere within the abdominal cavity. Why? Because they are now in the peritoneal fluid, and they are actually affecting all the organs from the outside, but they have the ability to anchor themselves on the outside surface of those tumors, creating tumor nodules that will eventually compress the inside of those hollow organs, in this case the intestine. So the same exact thing happens with the pleural cavity. The same exact thing happened with the CSF. So the minute that those kind of tumor cells break out, reaching this body cavity, they will be on their way to be implanted somewhere else. The same exact thing right here with the Krockenberg tumor, a tumor with a primary in the GI that give rise actually to tumor cells that will break and bathe into the peritoneal fluid, finding its way to deeper organs, growing on them, giving rise to this classic kind of presentation of a metastatic tumor in the abdominal cavity. Now, bone metastasis is a story on its own, because the most common site is going to be the vertebral column, when it comes to metastasis to the bone. The reason for this is due to the fact that the Batson paravertebral venous plexus is shared between the vertebral column and those of the visceral organs, such as the colon and other organs in those vicinity. So as a result of that, when there is a malignant tumor growing in those visceral organs, they are going to be using these venous plexus for drainage and on their way to the vertebra, especially the lumbar vertebra. The kind of presentation that you will see is one of two: either osteoblastic metastasis or osteolytic metastasis. Osteoblastic metastasis, as I mentioned to you, that's going to be resulting from the fact that the osteoblasts get activated or irritated, laying down new bone. As a result, you will see that there is increased alkaline phosphatase. And the prototype of this is going to be prostate cancer. There are other tumors that do the same, such as breast cancer. Here, an example of osteolytic metastasis, where you start to see widespread resorption of bone. Look at this. Okay, all of this is bone that has been eaten up by the osteoclast, that have been resorping actually this bone. In this case, this is the osteoblastic metastasis, where you will see that the osteoblasts are laying down new bone. Laying down new bone, so much so that you will start to not see the original or the way the classic shape of the vertebrae, what looks like a translucent shape of the vertebral body, because there's so much bone that has been laid down, what you call osteosclerosis. Osteosclerosis, or they call it a white out, because you don't see anything here. So now this osteolytic metastasis is showing up with so much resorption of the bone. You would think that right off the bat that the bone is going to become weakened, and as a result, pathological fracture may happen. What do you think is going to happen to those patients with the osteoblastic metastasis? Are they going to suffer any bone, or is the bone pretty tough now that you have new bone that has been added to it?
Suffer.
Rigidity.
They will have pain.
لا تكون لين فتعصر ولا تكون قاسيا فتكسر. What this is, what the saying is. Yeah, but not really. That's not really the way to think. This is the old Arab way to think about it. Go ahead.
Do you expect neurological symptoms?
Say it again.
Neurological symptoms. Numbness.
Not in the form of symptoms like what are they here? Here's a question, direct question. Are they prone to fracture?
Yes.
Why?
They're heavier.
Because no, there is enough time. Let me tell you, this is very fully mineralized. It will not look like this on X-ray without the calcium hydroxyapatite.
It will be more building up in a wrong way.
Wrong way. That's what they call a legal answer. You're right, but you're not really telling me what you mean by a wrong way.
These are the
What gives bone strength? This is from your experience in your one. Huh?
Regularity.
matrix.
No.
The shape.
10 times collagen.
Collagen and calcium hydroxyapatite crystal. All right. Well, also a legal answer. I hate to say that to you. Okay, it is actually what gives bone the strength. It's not really just the osteoblastic action. It is the dual action of the osteoblast and the osteoclast in what is known as
Deformation.
bone remodeling. Exactly. This is what gives bone the strength. If you put in only osteoblastic action, it will not result. So there are a lot of diseases that have a new bone formation, but the bone is weak and it is really very prone to fracture. Example of that here. So those patients, this and this are actually prone to pathological fracture, because the bone in this case has not been processed. Why? Because you have so much bone that is being laid down, there is not time actually for the osteoclast to come and process it, resorb it and process it, in the process of remodeling, bone remodeling, giving strength to bone. All right. So how does osteolytic metastasis, on the other hand, happen? In this case, you will see that the tumor cells will not do the bone resorption, rather they will be producing something that will activate the osteoclast. Either as a parathyroid hormone-like peptide, or an osteoclast-like factor, an IL-1-like factor. Both of them are going to activate the osteoclast, and the osteoclast will start the absorption of the bone, resulting in releasing actually the organic component of the bone from the inorganic component of the bone. And as a result of that, you will see that those patients are going to have hypercalcemia. Hypercalcemia is one, or could be one, of the early symptoms of malignancy in a patient. The most common cause of hypercalcemia in a hospitalized patient is malignancy. How about that? This is one of the ways in which hypercalcemia, in which malignant tumors may cause hypercalcemia. All right, here's a list of metastatic sites for colon cancer, but don't worry about it because I don't really like to list this kind of brainy stuff. I will not tell you where does renal carcinoma go to. No, I like the concept. Know the concept, you're gonna be fine in it. All right.